Good afternoon, and welcome to a very special cardiovascular medicine grand rounds. This is a person who's very hard to introduce because the facets of his work and impact are almost too large to imagine. One person affecting global cardiovascular care like Valentin Fuster. Dr. Fuster is the president of the Mount Sinai Fuster Heart Hospital, and he's a physician-in-chief of Mount Sinai Hospital in New York. He's also the general director of the National Center for Cardiovascular Research in Spain. It's the equivalent of the NIH of Spain. He has had a research career that has gone from basic fundamental science all the way to population health and poly pills in faraway places. He has probably elucidated mechanisms in atherosclerosis that you and I just take for granted years and years later. He has held the presidency of the American Heart Association, the World Heart Federation, and received many, many awards. I think he's the only cardiologist who's received the top research award from the AHA, ACC, ESC, and the International Society of Cardiology. And I know for sure he is the only cardiologist who has a heart hospital named after him and a Muppet named after him. I mean, who does that? Valentin Fuster is, to me, bigger in life. I had the pleasure of being a faculty member with him for a few years, and I can tell you his view of science and the world changed my thinking to be much broader. And we are just delighted that he's here today to give this important lecture. Valentin.
Thank you. Thank you. Let me just see. Well, thank you very much, Kim. It's a pleasure to be here, and thank you very much for your introduction. You are a critical friend, and you will always be an example. This is the fourth time I visit this institution, and I have seen the changes, very positive, and I came today because I felt guilty that I couldn't come a few weeks ago because of a strike in New York that I had to be involved with. But I am here today, and I'm very pleased to see a room which, with lots of young people. And this is always very attractive because you guys are the future. Well, let me tell you, about 15 years ago, I decided to change my line of research. I was working very much in understanding disease, and I decided to understand health. And why was the question? Because I think we knew more about what causes a myocardial infarction than how to prevent it. And this is a complete change. So I developed a foundation with three critical words: science, health, and education. And at that time, women in the cardiovascular field were not really taken care appropriately, and I hope this will change slowly. But the foundation is the She Foundation. Now, in order to address health, it's not easy because you want to address health from the point of view of research, in basic and clinical. It's not just preventing disease. So I decided to divide the population in three different ages, from birth to age 20, 20 to 60, and 60 to 100. When we address health, it's completely different, depending on the age that you are really applying this. So let me introduce the subject by saying that for a long time, it has been a sense that all the organs have some relation with the brain, including the heart. But it is interesting when you look at the peripheral organs, and even the heart has been neurological connections, mechanical connections, and biochemical pathways. But it's interesting that the mechanical connections that you would say, well, maybe something is affecting the arteries in the brain at the same time, mechanically speaking, blood pressure and so forth. This has not been part of the mechanical changes that are in the literature is how the receptors in the carotid system are stimulated and so forth. So when you look at this issue of the relationship between the peripheral organs and the brain, and you actually focus on the heart, there is a significant problem in the literature. And this actually until very recently. And this is basically what we are going to be talking today in part, is that the risk factors that affect the cardiovascular system are significantly affecting cognitive function in the brain. And this is something that is evolving at this time, but it's time to talk about because I think it's absolutely a fundamental issue. Let me go into the findings. And what we started 15 years ago is beginning to appear in the literature at this time. I mean, you need a long time to really look at things that may have some impact. We started on age 20 to 60, and at that time, we decided that we didn't have imaging technologies that were appropriate to go to a general population. I want to say from the very beginning that this discussion today applies to people in all the countries. Countries with low economy, countries with high economy, and so forth. So you cannot say, I'm going to do CT angiography and in the middle of the world, because it will not be affordable. So the approach is, what can you do to develop technologies that can tell you who is developing disease and then begin to act for? And this actually led first to the PESA study. The PESA study is based in Madrid, Spain, progression of early subclinical atherosclerosis. This is 4,200 individuals, 1,500 are women, who in fact we are following for 20 years. And we follow them every 3 years. First with imaging technology, vascular 3D ultrasound of the iliofemoral and carotid arteries, calcium score, and you will see recently we have in a group of individuals CT angiography, the coronary arteries, and positron emission tomography and magnetic resonance imaging. To go across the world doesn't mean that research has to be done on things that are affordable. It's not. We're trying to learn. Now with these technologies, we apply below the neck and above the neck, the brain and below the brain. And what this correlates with? Well, first, with more than 4,000 parameters of risk factors with AI and multiomics, genomics, transcriptomics, and so forth. This is done every 3 years. I want to emphasize this. And this has been blindly approached. So this is why the data is now beginning to evolve at this time. Well, let me tell you how this all started. Can we have a technology that will tell us that the disease in the arteries is beginning to develop? And we knew for a long time that this was a systemic disease, so we didn't have any problem in beginning with the carotids and the iliofemoral region. The technology that evolved over a number of years is 3D ultrasound of the carotid arteries. This is guided by artificial intelligence where the disease is. And with artificial intelligence, we can quantify the amount of disease that is evolving in cubic millimeters. Well, this technology has evolved very rapidly. We have done 12,000 people. But for example, in the recent meeting that we had in Madrid, with the European Society of Cardiology, we screened 500 physicians that they wanted to look at. The news are not good in terms of what we saw. And I have more to say in a moment. So with this technology, we began. And these are 7 things that are beginning to be actually at this moment in the literature, but I just want to emphasize 4 of them. First, the disease begins at age 30. And interestingly, 75% of the people is in the iliofemoral region. And this is very fascinating and to us, because we didn't even have an idea that they started so early and could be in the legs, the first region to be paying attention to. The disease progresses 33% in 6 years. But what is important is if you look at this disease, we did in 10,000 people, 4,000 went between age 40 and 55, the PESA study, and the other was between age 20 and age 40. What is interesting is that risk factors that are present between age 20 and 40, they have a tremendous impact over age of 60. I will present to you the data. In other words, if you have a high LDL at age 35 and the same LDL at age 70, the impact at young age is significantly higher. And the reason is that a healthy artery is much more reactive to a risk factor than an artery that begins to have some degree of disease. We have a lot of data on this, and this is actually published. But let me present to you how we obtained this information. This was from the Cardia study, a study of age 20 to 40, and about 3,000 individuals. And what we actually did is to look at the area of the risk factor, in this case is LDL, in this case is mean blood pressure. And what you do is over 20 years in the abscissa, you measure the area in the ordinate of how LDL is fluctuating. And this area we call burden of disease. And this is actually quantified. And the question is, what happened with these people when they were over age 60? So we had all the data of the cardia, and we went over age of 60. And it's very fascinating. Larger is the area of any risk factor that you talk about, LDL cholesterol, for example. Higher is the likelihood of cardiovascular events over age of 60, a very close relationship. We now found, for example, diabetes, which we know is important, but we didn't think was so important. And that is, at young age, just to have diabetes has a tremendous impact as compared with not having it, but these are other risk factors. What I'm really trying to say to you is that young age is critical, but we have ignored it because there was no technology telling us what goes on at young age. That's basically the issue. And we now have the data. Huge impact of risk factors between age 20 to 40 that come back later in life. But there's a critical question. Many of you will say the carotid arteries, iliofemoral arteries, we've heard a long time, this has nothing to do with coronary disease. Well, we just got the data, and the data is fascinating. So what we did, and this is completely blind, to look at what we found in the carotid and iliofemoral arteries, compare with now 500 people who we did CT angiography. And this is in the PESA study, the study that I just said from the very beginning. Well, here is the situation. This is 3D ultrasound of the carotid and iliofemoral region, but let's go into here. This is coronary artery disease by CT angiography. No disease, mild, moderate, significant. And here in the abscissa, no peripheral disease, carotid disease, femoral disease, a combination of both. And it's very fascinating because we found that in 70% of cases that we had disease in the carotid and iliofemoral arteries, these are young people, by the way, they had already coronary artery disease developing at CT angiography. But the other way around is also interesting. If you didn't have disease at all in the carotid or iliofemoral region, the chances of having significant coronary disease are close to 0, and with some disease in about 20%. So what this is telling us that we can do, and we are doing it, we are going to developing countries, and we already have this technology, which I will discuss more in a moment, and we can tell who is in trouble, who is not, by the concept that the disease is systemic. It's not just saying you don't have to go to the coronary arteries to know who is beginning to develop the disease. This slide is interesting. I don't want to go into the details. It's the same than before, but we did calcium scoring on everybody. Well, interestingly, and I don't want to disappoint those of you who are in the calcium score business, and that is if you are under the age of 50 and you have a calcium score of 0, the chances that you are wrong are pretty high. Because the disease as it develops, there is no calcification yet. The calcification evolves when it's the healing of the disease. The cholesterol gets out, you give statins, calcium comes in. But at this stage that I'm talking about, the calcium score can be completely 0 and the disease is developing. So we are, naturally I am in Medicare to try to pay for calcium scoring, but with a very clear concept, and that is in a very young age, the calcium score can be very not really suggesting of anything that is meaningful to you if it is 0. That's all what I'm trying to say. Well, having said this, we had enough information to go into the first randomized trial in young people, and this is the pre-CAT study. And there are 3 aspects I want to discuss before I go any further. These are people with LDL cholesterol, the PESA study, 4,200 people. What you see in color is subclinical disease in the carotid iliofemoral region or both. These are the guidelines. The guidelines tell you if you have no cardiovascular event and the LDL cholesterol is in between 80 and 110, this is normal. Well, it's not. What we found is that in apparently people without risk factors and at young age, an LDL cholesterol to be considered to be normal is less than 70. Okay, this has to be clarified because the guidelines will not tell you this. Why? Because we are measuring subclinical disease. This is the first point I want to make. The second point is, if you go to young people, what are you going to measure on a trial? You can only measure progression of disease. Our grandchildren will be able to tell us what happened 40 years later. But then we have a study, which is how we started, the bioimage study, that are people age 60. There were 6,000 people. In which we measured carotid disease by 3D ultrasound, as I discussed. And what we found is that at age 60, if you follow for 13 years, just at 3 years, progression of disease meant cardiovascular events. This is what this slide says about it. So if we design a study in people who are relatively young, as I am going to show you, the endpoints cannot be hard endpoints as I am showing here. But at least we know that the progression of disease means events. And actually the events are much higher if you are younger than if you are older, as it is here. So that's basically the statisticians were all in agreement that we were ready to do a study on young people with LDL cholesterols higher than 70 and begin to see a progression of disease with aggressive treatment. What is the aggressive treatment with an LDL cholesterol in a young person that is over age of 70? Most of them were already with disease in the carotid or iliofemoral region. Well, you will say statins doesn't work. In fact, we started young people with the statins, and I can tell you 80% stop the statins in the first time that they have to go to refill to the pharmacy, the statin. It doesn't work. This led us to go into the liver and begin to use a drug, as you know, is inclisiran, with 2 subcutaneous injections a year. And basically what inclisiran does, I don't want to go into the detail now, affecting the RNA, you end up with a lower cholesterol level by affecting the PCSK9. And this lasts for a long time when you get into the liver. So then we decided to restart the study, not with the statins, but with inclisiran, and this was the design of the study. 2,000 people between age 13 and 49 with an LDL more than 70. They may have disease in the carotid iliofemoral, they may not. We think is a problem, but we follow the development of disease or new disease. In the above group is inclisiran treated, and this is the control treated as it is with guidelines. Well, what is interesting is with the statins, we're not able to enter people. With inclisiran, we already enter in 6 months 400 people in the study. And that is young people accept to be treated with a subcutaneous injection, which is about twice a year, and not with the statins. And this is the study is going on. I cannot present to you data from the study, but I will tell you that the data is so interesting that we then decided with Denmark to develop another study, the so-called REACT study with 16,000 people. This is not just 4,000 people, 2,000 people. And basically, these 16,000 people, we look at the carotid arteries, we look at the iliofemoral arteries, and we do CT angiography in 10,000. And all of this is just to really put a stamp into something that we already know, but that cannot be debatable when you are really with a large population. And the question is, what is going to be next? And the first thing with the REACT study is first to have the technology with artificial intelligence assistance and so forth. This technology, you don't have to be a technician to do it when you have AI following. Any of you can put the device and follow very easily and come up with the phone and telling you exactly the amount of disease that is present in the iliofemoral or carotid region. This probably will be available to the public in about a year from now. But this is the first thing of the REACT study, to have the technology absolutely that can go to the public. And the second then is what trial we are going to develop with REACT. And we are waiting for the study, the pre-cut studies, all at Mount Sinai, the pre-cut studies, all in New York. And the REACT studies between Madrid and Denmark. That's the difference. And then we'll see what we are going to do. Well, I mentioned to you that subclinical diseases start early in life. Whatever you have risk factors at young age end up with a problem later in life. The technology we are using is a new technology. It took 15 years, by the way, but that's what it is. And really correlates peripheral disease with coronary artery disease. And this led to, from the PESA study and the cardiac study, led to the pre-cut study and to the REACT study that are ongoing now. But there's an aspect that was quite of interest to us, is the microvasculature. We decided to study this in detail in the PESA study, a study that we go for 20 years, every 3 years. And we use stress MRI, as those of you who are knowledgeable in how to address the microcirculation, this is probably the best technique available. Well, we used this technology in the PESA study, and we were very surprised. First of all, cardiovascular risk factors lead to disease of the peripheral arteries and the coronary arteries. I already showed this. But what we didn't realize is that in the people that we did 453, we assessed microvasculature, age 40 to 55. Those who had 2 of the 3 risk factors I mentioned, hypertension, high cholesterol, diabetes, 2 risk factors, 40% had microvascular disease, which was completely silent. This is young age. We are not talking about people age 60 that you don't know and so forth. We are talking about people who are young. So the microvasculature is being affected in the heart, but it's not symptomatic, and we don't have any idea who has it, who doesn't. But this is showing to you the power of the microvasculature. And now I don't want to go into the details. We are measuring this not only in the heart, we are measuring in the eyes. And I don't want to go into the detail. There's a lot of information there. But most importantly, we got into the brain. These microvascular findings led us to really begin to focus all of our attention with the most modern technology into what it is, cognitive function of the brain. And that's what I'm going to be talking in the next few minutes. So between age 20 to 60, I mentioned to you that we are very excited because we feel that we might be able to do a technology is very simple, extremely low cost. We can go to any country in the world and we can tell there's no need to do CT angiography of the coronary arteries, but just to address subclinical disease early when we can do something about it in the prevention of disease. This is basically what I can summarize at age 20 to 16. The pre-CAT study and the REACT study are studies already trying to treat these people. In the brain, there are age 60 to 100, and the question is, what happened and what we have learned? Well, in the brain, there is one issue. You say, well, there is data in the literature, and this is from the ARIC study, that intracranial atherosclerotic disease in the circle of Willis can really have a role in the development of dementia. This is a study published a year or 2 years ago in near 1,600 participants with a follow-up of 6 years, 5.6 years. I was not turned on by this. I will tell you why. Because what they show in the circle of Willis and in the carotid artery was not obstructive disease. It was a little bit of disease. In a little bit of disease, without creating obstruction, how this can lead to dementia. And we reached the conclusion that some disease is a marker of something else that may lead to dementia rather than the cause of dementia. This was large vessel disease. And actually, this is the data. Over 7 years of follow-up, they found a little bit more dementia in these people that they had disease in the circle of Willis or carotid disease, but there was not obstructive. I think this is a marker. This was our feeling. But then we were starting already to do work on the brain with the technologies that I mentioned. And one of the first technologies we used was PET scanning and flow in the brain with MRI. That's how we started. Well, we started with 370 people of the PESA study again. And what we did is we followed these people for a few years. And what we did is the uptake of glucose in the brain of people who have 2 of the 3 risk factors I mentioned, as we did with the microvasculature. And what we found is over 3-4 years, there was a decrease in the uptake of glucose in people who had 2 risk factors of the 3 I mentioned. What was fascinating to us is we did blood flow with MRI, and I don't have to go into the details, but just to show to you that something happened between the MRI with flow, and that is, and the problem in the brain when the flow is decreased with uptake of glucose. We published this in The Lancet, the first part with PET 2 years ago. This is going to be published soon. This led us to the concept that we are addressing at this time. And that is, the risk factors do not affect the large vessels. They may, but they don't cause problems to the brain. But they affect the microvasculature, which is what they were going after. And actually, the pathologists today are beginning to publish what we are finding functionally. That is, the microvascular of the brain is affected by the conventional risk factors that are affecting young people already, as I mentioned to you. We are really in the subclinical disease area. So with this in mind, and with all this preliminary data, then the studies are beginning to evolve. And that is very complex. Vascular cognitive permanent dementia, risk factors contributed a small large vessel disease. This is small vessel disease. Large vessel disease, strokes and so forth can affect, obviously, cognitive function. But this is the area that we feel is absolutely critical. This led in 2022, when we're already getting the data, to have a prospective study, the PESA brain study. And that is 1,000 people that we are following, again, consistently, and with all the technologies I mentioned, PET, MRI, but much more sophisticated than that, because you don't look at flow only, or you don't look at the uptake of glucose, you look at amyloid and so forth. cognitive function is being addressed, and then obviously biomarkers. This is a study, it's a prospective study that is going on at the present time. What is important is that we and others are beginning to get into something very interesting. That is, of all cases of cognitive impairment and dementia, cardiovascular risk factors contribute directly to 20%. That is, 20% of dementia is vascular. But they contribute in part to the majority of cases with dementia. And that is directly is one single cause, but in all the cases of dementia, they may contribute. And I have to say the following. In the study that we did with the uptake of glucose, we found that the areas of decreased uptake are the same areas where Alzheimer's developed. So our concept is Alzheimer's is a complex disease, but the progression of the disease may have a component of risk factors and vascular that make the disease to progress faster. That's the point, which is more complex than the other cases of dementia. Well, anyway, I just wanted to make this point. But here's the story. As we were working on microvascular disease, something came up that was quite interesting. We have a model in Madrid of Alzheimer's disease in animals, in rats. Very interesting. And we began to publish this in 2024. And that is, if you look at cerebrovascular pathology in Alzheimer's disease in these animals, you see clots that are in the area of amyloid deposition. Amyloid is prothrombotic. Now I have to show you more data. This is the animal in the mouse model where, in fact, they develop blood clots in the areas of amyloid. What we did is we give dabigatran, and we could prevent the progression of the disease. And this story was actually post-mortem. That is, this was seen in the rats post-mortem. But now we have in vivo data in the same animal model, which is using PET for the identification of fibrin formation, which is here. But if you look at this is fibrin formation compared with the controls. You see the color. But then we went to humans. This is in the last year. And this is post-mortem again. And we are fascinated by the fact that in Alzheimer's disease at post-mortem in humans, we feel fibrin deposition with PET and platelet also deposition, also with using these technologies. And actually we can see this. And this is in humans. So when we talk about microvascular disease being important, maybe risk factors cause intimal thickening. It's not atherosclerotic disease, and they impair flow. But there is something else with amyloid that makes things more complex. And this leads to, I don't know, those of you who read Alzheimer's, what he wrote about 100 years ago, more than 100 years ago, my disease is an arterial disease. What is fascinating to me of Alzheimer's written reports, he never pointed out what arterial disease he was talking about. And the question we have today is, was he seeing microcirculation with intimal thickening? Was he seeing perhaps something in the circle of Willis, which could be a marker? Or was he seeing clots? Whatever it is, but this is how he defines his disease, an arterial disease. And interestingly, the whole research has been into the cell. And this makes sense, cognitive dysfunction. And probably is a way to go. But we have science to say that vascular disease is important in dementia, and it's important in dementia, not only in vascular dementia, but perhaps in the progression of other types of diseases. And this is actually, I think it's published this week, is vascular cognitive impairment and dementia. They are go together. 15 to 20% of all cases of dementia are vascular in origin, and 75% of dementia of any kind, there is a vascular component. What I'm really trying to explain is that we are in a new era now with new technology that is beginning to address what in the past is before the disease takes place, what is really the triggers and so forth. And this is why we are fascinated by being working in this field of understanding health. And we are beginning to see the importance of young age in the prevention of later disease. I just want to make a comment about blood tests that are now approved for Alzheimer's, p-tau 181. If it is negative, it rules out Alzheimer's at 10 years of follow-up. Now, the other one is Lumipulse. If it is positive, this is maybe suggestive of Alzheimer's. The most important thing, I wouldn't do this testing at all unless the patient has symptoms of cognitive decline. To send the population to do testing and to begin to make people neurotic when you don't know what the tests really mean in terms of sensitivity and specificity is completely wrong. So the only point I'm trying to make is within a research arena, we are measuring all of this in all the studies we are doing, but we are very, very careful in saying who is positive, who is negative, and this means you are going to have Alzheimer's or not. This is actually in the IRBs, in the written, this is not notified, okay, because we feel insecure. Well, the final point I want to make is if risk factors are important in vascular dementia and in other types of dementia, hypertension, cholesterol, and diabetes, that's what we found. But there is something else that I now want to present some data. That is, dementia is not only that, it's isolation, social isolation, lack of exercise, and lack of motivation. Now, I'd like to point out this for a moment. 2 studies. The US Pointer study, 5 centers in the United States, 2 years of follow-up lifestyle intervention, 2,000 people at risk of cognitive decline and dementia. What these people were, they were randomized into 2 groups. You probably are aware of the study. One group, the risk factors were aggressively treated. And at the same time, social isolation, motivation, and exercise. In the other group, served as controls. The results were very positive. But the question I have is, how in 2 years, addressing risk factors, you can change cognitive function in an individual? So I had to be convinced that was the part of social isolation, exercise, and motivation that was really turned positively in those who were intervening in that regard. And then you can have short-term effects. The other study was just published too. But this is the one that to me is the most interesting one, is from China. The effectiveness of blood pressure reduction on the risk of all-cause dementia. Uncontrolled hypertension individuals, 33,000. They were divided in 2 groups in the rural areas in China. Those that blood pressure was treated very aggressively, and systolic blood pressure, an average of decrease of 22 millimeters of mercury, in those that were not treated as aggressive. Significant results. And these results, what is important, is in about 4 or 5 years. Here is where I think that the risk factor aspect of cognitive dysfunction may have an effect, is in a long follow-up. And I would say it's never late, because I think the average age of these people was 62 years. So the point I'm trying to say is a very complex disease when we talk about cognitive dysfunction. But those in the cardiovascular field, if we don't get into the brain, we are getting primitive. Because the same risk factors that are affecting young people at long term may affect people that are really in the issue of cognitive dysfunction. And, you know, this is where we are at this time. All we are with trials. The PESA brain study will give a lot of information. And all the data I'm presenting to you today is data in the last year or 2 after 15 years of work. But now I want to finish with the most important part, in my view, which is the SHE study. Where I've mentioned to you, I had a foundation, Science, Health, and Education, and led me to everything I'm presenting today. But there is a specific study in children that is called SHE. And the question is, why you are getting into children? Well, this is the Lancet Commission just published in adolescent health and well-being. Children and adolescents are the future leaders of the world. We must ensure their health and well-being to secure a more just society and a healthier and more productive planet. That's why when I started to say, I see lots of young people here, I feel good, because that's the future, whether we are in agreement or disagreement, that's what it is. Well, it turns out that I had an influence by a brother of mine. This is well known in the field of the frontal lobe. He's at UCLA in California. And he developed the concept that whatever we tell a child, frontal brain, in the first 10 years of life, sticks into there for the rest of their lives. And the question is, if you, like you are sitting here, if you remember the first 10 years of your life, family, environment, school, you will see that your weight you are today has a lot to do with that time. I don't think this is something you can reject. Now the question is why, and here's the key. The key is that in the first 10 years of life, the number of receptors in the brain is relatively small. Later on is a chaos and all high density, and there are lots of interactions. So what you tell a child, there are no interactions, is just fix here. Later on is very complicated. You talk to an adult and things get from one ear and leave the other. There is no fixing. There's too much interactions, too many things that intervene. So the concept was, if these first 10 years of life have a lot to do how you are later, why we don't infuse health as a priority to these children? And this is how we began a huge educational program in children. We are dealing with 50,000 children around the world at this time. But this is how we said it's absolutely critical. Of all the research one can do at age 20, at age 40, 60, 100, we still have to get into education. And perhaps the most important time is childhood. We did 4 projects. I think this is actually in the previous slide. 4 randomized projects with 3 conclusions in over 7,000 children. What I'm going to be presenting is all randomized. There is no study I have done that is just descriptive. And this is the one. We started in Bogota, Colombia, age 3 to 5 years, and then in Harlem, New York, simultaneously in 2 socioeconomic different settings. Over 1,700 children, they were randomized into intervention and no intervention. And what we look at is knowledge, attitude, and habits. Significant good results. Here is Bogota, this is Harlem, and in red is actually a control. Here is the intervention. But here's the problem. Habits, attitude, exercise, this is all not too tangible. What about biologically? The only way you can address biology is fat, obesity in children. And that's what we did. We then went to Madrid and we did a study between 3 to 10 years. Most of the children were actually close to 10 years, 8 years. And we followed them for 3 years in the same educational program that I didn't present to you, but I think it's time to, I would like to make. The interventional program is 60 hours over 6 months, how the body works. You cannot go to a child and say anything you want if they don't know the physiology, how the food goes in and out and so forth. They have to understand it. Healthy food habits, physical activity. And finally, to control the emotions, what we do is, again, I'm not an expert, but I learned to be a little bit of an expert, is you create self-esteem in children. It's interesting because we tend to criticize them or to give everything they want. No, it's to create self-esteem. We say you are above somebody that in later days they're going to present to you with alcohol, tobacco, and so forth. You are above them. So you give them the sense they are somebody. Very fascinating. This really works. These are the 4 things we do, 60 hours during 6 months. And these are, when I presented these results, this is what it is. We look at attitude, knowledge, and particularly things that are more through talking to the child and talking to the parents. But here we've gone into adiposity. And that is, we did the same thing. The 4 aspects were presented, but we look at adiposity in the most sophisticated ways. I don't have to go into the details. But here is lipid deposition in terms of which your the legs and arms. This is the circle of the waist, and this is the BMI. You see, this is the group that is controlled. This is the group that is being intervened. It was very fascinating. This is the only study I know today in which intervention at young age can have an impact on obesity and the deposition of fat. And this was done over 3 years of follow-up. Well, everything looks good in the first studies, 2 studies I'm presenting, but things are never so good. What happened is the children in Bogota that we intervened between age 3 to 5, we were at age 10, we look at what they remember of what we told them, compared with the group that served as controls that were intervened. No great difference. So at that moment, you can quit and say, you know, I have been wrong, and that's it. But thinking, we thought maybe they have to be reintervened, and that's what we did, and was fascinating. If you reintervene, the results are amazing, are exponential if you have been intervened before. Okay, so in other words, compare with groups that only intervene once. This is very fascinating to us because we found this in adults. In many things we did in adults, we have to be reintervened constantly. Otherwise, when we are there, we go down. We have to be reintervened. So we found this in children. And this actually led to the project. Actually, we have 2 projects in 1,000 children now in 50 schools, in which we intervene once, here again, and here we only intervene one time at 10 years of age, and then we follow at 12 years of age. We are absolutely convinced that reintervention is the name of the game. Well, having said this, then we decided that something very interesting, the control groups that we did in all these studies, they did much better than what we expected. And the question is why? And we thought was the environment. This was in the school system. So if you go to a school and you divide the school in a group that is intervened and a group that is not intervened, what is interesting is non-intervened group, they do reasonably well because they are in an environment. So we decided to get into the family. This is the 4th project. And we decided to go into the families and do the parents, children, and grandchildren over a period of 1 year. They go 3 times through exactly what we told the children in the first few studies we did. But you say how you're going to say how the body works in an adult that is age 70. This is done with different degrees of maturity, the same questions. But we did that. The results were fascinating. We have done this with industry. People who are the workers of a bank, for example. And we present them, do you want to participate with your families? The results have been fascinating. We have data with 400 people now. But we went also in Latin America to the waiting offices of patients. And that is physicians having the monitoring where you are waiting to see a physician. Do you want to participate as a family in a project for the next year? We did that, and the results were the best we have obtained thus far. Is at the moment that you work with the environment, not only with the kids in the school system. Well, this led to the 3 things we have learned. First, I didn't mention, but adherence to what we do is absolutely essential. That is, kids have to really show up to these interventional aspects. They have to show up. And this makes a tremendous difference. The environment is a tremendous difference. Sustainability, that is, reintervention, is absolutely critical. We have good data until age 15. The question is, are these reinterventions for how long? We are doing until age 20 now. How is this going to work when these individuals are age 60? I mean, I don't have the answer, but the concept is there, and this is how we are pursuing. Well, this led some organizations now who have followed all of this into beginning to listen and to try to get into education. And one of them has been actually American College. I'm sorry, my name is here. It's just the way the application has gone. Basically, this has been sent, and you have received this, those of you who are from the American College. If you want to participate in an educational process in June, which is 2 days here in Washington. And what the cardiologists will do, will go into their communities, school of their children and grandchildren, or they will go in their offices to teach exactly what we are doing. And the teaching is fascinating. It's all imaging. There are no words. And that's where you saw Muppets at the beginning, that my presentation today is all goes in that direction. And this is actually what is going to start. We are going to do this in the next 3 years in the United States, and then we are going to do it internationally with a preliminary data we are obtaining in Mexico. So I'm going to finish here by saying to you that this is what I presented to you is a 15-year deal of working on health with the data beginning to evolve now. And the thing I would like to summarize is we can do a lot on prevention. I think starting with imaging technology and risk factor profile in a very economic way, as I mentioned. And it's going to be, I was at NIH just a few weeks ago because they want to take this seriously, which is 3D ultrasound with AI of the carotids and iliofemoral region. And we can go to countries without being technologically savvy. The brain is becoming very critical here, and that is no attention has been paid on cognitive dysfunction because there was no technology. And it's a little bit scary to the fact that things begin to cook at young age. You know, all these risk factors and the microvasculature, as I show you today. And this is something we have to really begin to pay attention to, which means that probably the next guidelines, and I know is the case, are going to begin to be focused on subclinical disease for the first time and in young age, starting at age 30, which is really what we found. But I don't want to finish without emphasizing education here. And that is, to me, the most important time of educating people are in young age. I think we have questions, how this is going to work with the reintervention, until what age, what will be at age 60, but at least to me, at this moment, is the way to proceed. Well, I really appreciate very much this opportunity. As you can see, I'm very excited. I say life is motivation, but I think I'm excited because I think this is relatively new, but to me, it can make a change, is to really work into subclinical disease and education. Thank you very much.
Amazing work, beautiful presentation. Are there questions for Valentin? I'm going to start. You mentioned a module for emotional support for young people. What does that look like?
Well, basically, what we teach, and this has been led by the psychologists, what we teach is you are age 7, you are gold in this world. You are important in this world. But you have to recognize that there are people who are going to get into you and to do things that are not right. And the examples we put is alcohol, drugs, and so forth. And says, whenever somebody approaches you in the near future, which offering you this, remember that you are above all of this. This is actually the teaching. And I'm saying because we're already beginning to have experience. This aspect is the most important aspect for the parents, actually, of the whole interventional, but it's beginning to play a role. And I think we learned something, and that is we as parents, and I think we all have the experience, we have been either giving to our children what they want or punishing our children, but we have not been creative enough, I think, in trying to make them feel that they are important, and they are, and that aspect, which is in between both, is what I think is missing. And what we are finding in this study, and this appears to be working on, is to provide self-esteem at a young age.
Let me ask another question. For the 30-year-old, are you doing carotid imaging now? Is that standard for you? And what age do you start your calcium scoring?
No, it's not a standard. We are doing it at the present time, not only in the pre-CAT study and in the REACT study, but we are testing this in Mexico and in other parts of the world. But it's not, has to be approved by the FDA. as a technique that will be worldwide, but this is already moving in that direction.
We get asked about the Clearly CTA scan all the time. This new CAT scanner that can give you not only a plaque, but functional reserve. How do you feel about that?
Well, I feel these technologies are very interesting, but cannot be applied to the rest of the world. To me, a critical issue, if you really want to get into prevention, is you have to prevent the whole world. That's how we got in something I didn't discuss today, which is the polypill. The polypill evolved from the Freedom trial, in which people who were randomizing to cabbage in PCI, all very interesting diabetic people. Cabbage is better, but only 20% were using the appropriate medications to prevent disease. This led to the polypill. Here's the same thing, it has to be for everybody. You cannot just use technology that's only for few people. And I think that to me is a critical issue, that we can go to the world and be able to do something that is meaningful. That's basically the philosophy.
David?
So first of all, thank you for coming to Michigan. You inspired so many people, including me early in my career. I thank you for that. So I have a question. It's a chicken or egg question. For the 20% of people who have cognitive decline and atherosclerosis, is the atherosclerosis the cause, or is there something that causes atherosclerosis, metabolic syndrome or something, that also causes vascular decline?
Well, first of all, we don't think it's atherosclerosis. We think it's intimal thickening. Remember, many times when you do carotid studies, we talk about the intimal thickening of the carotid artery. I think this happens in the microvasculature of the brain. And it's not atherosclerosis for the pathology, it's intimal thickening and closes the vasculature. Now, to talk about the cause or the consequence, it's hard for me to see how dementia can lead to this intimal thickening. So I have to confess that common sense tells me that the thickening of the artery, of the arteriolar system of microvasculature causes the dementia. I think we will learn this in the brain PESA study, because we follow people progressively and we know what starts and so forth. We measure cognitive function, everything. So we will know, but I have to confess that to me, most likely is the risk factors are affecting the microvasculature, and the microvasculature leads to the cognitive dysfunction.
I don't know this to be applicable globally, but has there been anything looked into preventive testing that exists already, utilizing that further for risk assessment, such as a mammogram has breast arterial calcification? Would that have any bearing to utilize in sort of that early population that's getting screened already?
Yeah, well, the question is other preventive measures, mammograms and CT scans, looking at calcium. There is a movement. This is all what I can tell you. There is a movement now, we all know, in time to have a screening, of all the possibilities of disease, including cancer and cardiovascular disease at the same time. I am all for that, but I think this applies to a very small population. And that's where my problem, or at least one of the problems is that you cannot go around the world with CT scans and all of that, because it will never work. So I think I am all for these advanced technologies, and we should reinforce that. But I think we have to be very aware, if we want to have an impact, we cannot have it just in specific people. One of the paradoxes, and we were discussing this morning with your colleagues here, one of the paradoxes in the United States is the money spent on technology is the highest in the world. And if you look at morbidity and mortality of disease, is in the highest of the world too. So something is happening that is wrong here.
Teresa?
Thank you for coming. I don't know how to make this work. Thank you so much for coming. I'm one of the cardiology fellows. My question for you is, in your future research, do you have an intervention arm for young adults ages 18 to 30? Because just in my experience, what we really want to change is lifestyle and diet. And in a child, that's predominantly dictated by their parents. But the young adult is the person that I've had a hard time either encouraging, but they also need to learn a new skill set that they may have never been taught.
Yeah, interesting question. We have a paper coming out on this, and it's actually 2 towns. The town that my wife was born is 5,000 people in a town that is 50 miles south, Cheyenne, Cardona and Cheyenne. And what we did is we pick up people between age 20 and age 80. And these people are trained, in one town is intervention, the other town is control. The intervened town, there are 5 different classes or presentations about what you say. Prevention is all teaching, okay? And in the other is all control. We measure risk factors in both. And in the control town, you say, well, how people can participate if you are a control town? Not only we measure every aspect, but we treat the children of the families who participate. At least they know we are taking care of somebody. The results are fascinating. And it's basically the number of classes you attend, lower will be the blood pressure, lower the cholesterol, lower the smoking, and so forth. So in fact, we as adults know what we have to do. The question, are we interested in participating or be part of it? But with answering your question, there's no question we can have an effect in people, but the people have to be ready to change their lifestyle. And if you are ready, you participate in what we are talking about. You as physicians, you don't have to participate because you know the problem, but the general population can. I feel this is a very critical question, and that is, we can get into adults. We know what has to be done. The question is, do we want? And if we want, it just works.
There's a question.
There is a Zoom question. So Zoom question from Dr. Jeffrey Williams. In the studies of young children improving emotional regulation, are you measuring, assessing personal autonomy and parental support of autonomy? A side comment to that, according to self-determination theory, autonomy is a second psychological need in addition to self-esteem, which is a key to motivation and well-being.
I agree, but you see, autonomy at this young age, 3 to 5, is unteachable. I think the concept is an important one, and that is later in life. You cannot go to a child age 4 and just trying to create autonomy. It just doesn't work. But later on in life, and I think this is important and is well known, between age 10 and age 15 is a critical age that we are working, we are thinking about this, but not in our studies thus far.
So I think that I can speak for all of us. I mean, Valentin's career has taught us a lot, but more importantly, the way he's carried his life has inspired us a lot. Every interaction I've ever had with him, I want to strive to do more because of what he's proven is possible. So thank you so very much.
Thank you all. Thank you. Okay.